Good evening, and thank you for allowing me to present our work. I have nothing to disclose. Surgical training continues to be in a state of transition, from focusing on operative volume to centering on efficient and effective intraoperative teaching. Intraoperative decision-making remains one of the most important learned skills in the successful completion of any operation. Attending surgeons are often systematic and automated when performing surgery, which creates a challenge when instructing surgical trainees and leads to decision-making often being overlooked in the current training model. In fact, expert surgeons have been shown to omit 50 to 70% of information when instructing trainees in the operating room. Cognitive task analysis affords experts the opportunity to articulate operative steps with the cognitive thought processes used to determine their intraoperative decisions during complex operations. These steps can then be used to develop central teaching points within a case. This methodology has been shown to hasten the retention of technical skills and decision-making in many surgical operations and procedures. Laparoscopic cholecystectomy is the most common operation performed worldwide by general surgeons. Despite this, the incidence of bile duct injury has remained stagnant. Additionally, studies have demonstrated few associations between technical, patient, and hospital characteristics and the injury rates. Therefore, it is essential to also consider the roles of education, decision-making, and experience in preventing patient injury during this operation. The aim of this study was to use cognitive task analysis to expand a laparoscopic cholecystectomy into microsteps, reflecting expert surgeon cognition, including perceptions, real-time assessments, and intraoperative decisions, with a focus on patient safety such that these could be formalized and conveyed to residents in educational materials and to educators as eventual teaching scripts. One surgeon, a surgical resident, and a human factors specialist conducted cognitive task analyses with 3 expert general surgeons and 1 hepatobiliary surgeon. The surgeons were selected for their subject matter expertise from all levels of practice at large academic medical centers. They were interviewed using cognitive task analysis methodology along with semi-structured interview techniques. Each interview was recorded and expanded on an existing task model to develop one centered around patient safety aspects. Following this discussion, each of the surgeons was asked to consider a difficult laparoscopic cholecystectomy they had performed and discuss the patient safety issues they considered at each step. Audio recordings were ultimately transcribed, analyzed, and a cognitive demand table was created by the human factors specialist. Cognitive task analysis expanded the existing laparoscopic cholecystectomy model from 19 to 97 microsteps. In addition to microsteps, an additional major step was identified, step 0, or the planning step. 2 of the 4 expert surgeons identified step 0 as missing from the existing task model. Both described this as the planning step and described actions that one should take prior to positioning, draping, and prepping the patient, as evidenced by the supporting statement shown here. This included anticipating abnormalities with the patient, identifying and mobilizing any resources that may be needed, knowing what instruments are available in the operating room, and discussing these plans with your operative team. 2 steps, dissection and intraoperative cholangiogram, were identified as having the highest cognitive load, both based on the number of microsteps within each, with 15 and 10 microsteps respectively. The supporting statement shown here also demonstrates the cognitive load that both of these steps are associated with. Both steps centered around the discussion of obtaining an adequate critical view of safety, which all 4 of the experts agreed should be the goal of dissection in every laparoscopic cholecystectomy. If unable to be appropriately obtained, all 4 recommended proceeding with the intraoperative cholangiogram. Interestingly, the 2 most senior surgeons who are the experts who identified a lack of step 0 on the existing task model presented at the time of interview. Both had very similar explanations for the addition of it to the task model, and both highlighted the importance of performing this step prior to incision. In reviewing the literature covering previous cognitive task analyses, ours is the first to include this planning step. Like the existing model for laparoscopic cholecystectomy used for this project, the models for appendectomy, Nissen fundoplication, and several procedural skills begin with patient positioning. Additionally, the dissection of the critical view of safety has the most microsteps and the highest cognitive load. As mentioned previously, studies have shown a lack of associations between technical, patient, and hospital characteristics with bile duct injury during cholecystectomy. Thus, it is essential for surgeon educators to recognize the role of education, decision-making, and experience when preventing patient injury with this operation. The cognitive task model developed from this project provides the framework for integrating all three into intraoperative teaching and protect our patients from iatrogenic harm. This work should be considered regarding some limitations. One is possible lack of generalizability. We attempted to limit this by interviewing multiple surgeon experts and including a hepatobiliary surgeon not associated with our institution. Additionally, all 4 surgeons attended different residency training programs and fellowships. A second limitation could be a lack of consensus required of all 4 expert surgeons for a microstep to be included. We purposely chose to forego this requirement as our goal was to create an exhaustive list of cognitive decision points regarding potential patient safety errors. In summary, laparoscopic cholecystectomies are complex operations with many steps representing opportunities to teach intraoperative patient safety. Cognitive task analysis allowed for deconstruction of essential operative steps and decision points into microsteps. These results provided a scaffold to identify the critical teaching principles and guide intraoperative instruction of surgical trainees, and led to the development of a rubric for evaluating intraoperative patient safety teaching. Future interventions will utilize this rubric and ultimately teaching scripts to ensure transfer of knowledge from the expert to the trainee. The references used for these slides are listed here. I would like to thank our human factors specialist partner, Dr. Rothwell, for his help with this project, along with Dr. Huang for her help, patience, and mentorship. I'll be happy to take any questions. Thank you.